Hello, this is Parsa Zadeh, and I'm doing a procedure today of extracting this cracked tooth and replacing it with an implant on the same day, and then covering it with bone graft and GTR. The procedure is done in one visit, and this is a good service that we take the tooth out and replace it with the implant the same day, rather than bone grafted and then have the patient come back 3 months or 6 months later. This is the preoperative PA of the tooth number 18. As you can see, this root most likely is cracked based on this widened periodontal ligament space, and there is an abscess here. So patient has a lot of pain, and that's why she's come to take care of the painful situation. 3D imaging of the tooth number 18. We can see the infection on the root here. It does show a very thin buccal plate and shortened buccal plate, so most likely we're going to lose this buccal plate when we take this tooth out. As you can see, it's almost perforated here, and that's where that so-called gum boil was there. Another important thing to notice here is the nerve is all the way down here, so we're not anywhere near the nerve. Another thing I want you to notice, which is the subject of a few of the videos, is that there is another area here that by itself can look like a small nerve. Now, fortunately, both of these are away from the area we're going to be working. But if we were counting on the exact distance of the working area to the infraalveolar nerve, we should not ignore the smaller area on top, because I have seen cases that there are two nerves coming down to the mental foramen and the anterior region. And even though one of those the main nerve is preserved, the smaller nerve, if that has been penetrated, then the patient will experience the numbing. So this is a good case to show that there are two. This is one of those cases that are two nerves involved. It doesn't show it clearly on this view, but on the cross section we can see that. This also goes under criteria of avoiding nerve damage and the lower implant placements. Okay, so as we can see on this X-ray, the second molar has a lesion around it, and patient has severe pain. And soon I'll show you with the intraoral video that the tooth does have a abscess, a gum boil. Actually, you can see here on the buccal there's a gum boil, and on the lingual also. So we'll start by numbing the patient with the infraalveolar block, then placing an incision around the tooth here to separate the gum from the tooth. And of course this crown would come out very easily, so we'll have to most likely split the tooth, which the crown came out. I have used the 557 surgical to split the tooth. Now this is a mesial root that comes out. You can see the crack line and the granulation tissue connected to the tooth. And now we're taking out the distal root. The distal root didn't have the infection, so it was a little bit more difficult to remove. Now we are removing the remaining granulation tissue in the socket with the spoon excavator. The tooth had a chronic infection. A very, very critical step for immediate placement is neutralizing the lower pH caused by the chronic infection. This is sodium bicarbonate, USP. So the cotton is soaked with sodium bicarbonate, USP, and it's placed in for about 10 minutes or so. very, very important step is to remove the cotton when we want to continue the work. So now we have an area that its acidity is neutralized, and this makes it okay to place an implant same day. So first, with the surgical round burr, I'll split the septum of the socket. That's what we're doing. Then I will check the length of it by using a body drill for the proposed implant size. And then I'll use the head drill right after that to make sure there is enough room for this is the head drill. The head drill goes in easily, so the area is suitable now to receive an implant. I've chosen a 6.5 by 8 millimeter implant to go in this place. Implanova implants, they go up to 8.5 in width. So this is a sizing instrument for the 6.5, and that's a 6.5 implant that goes into that septum area that we created with the round surgical burr. It has primary stability, as you can see. On the lingual, it's much lower than the crest of the bone, so that crest of bone is lowered down to about a millimeter above the implant site by same surgical burr. A healing cap, a cover screw covered by triple antibiotic ointment is placed into the implant, and that's because invariably the blood gets into the implant chamber and the hex area of the cover screw, and that can create infection later. So we cover that with the triple ointment antibiotic. This is collagen. I'll replace the collagen for the buccal wall that was missing and short to some degree where that abscess was. Now remember, we cannot suction at this point because the suction will remove the collagen, or if you have placed bone graft there. Now we place the bone graft on the buccal area. Now that's the bone graft covering the space between the implant and the buccal mucosa. More bone graft to fill in any empty spaces there. And this is Teflon. It's a non-resorbable guided tissue regeneration material. We put it to cover the missing buccal wall and the occlusal area where the tooth came out. Remember, it is not necessary, and actually it's contraindicated here to stretch the buccal mucosa over it because we want to create attached gingiva more than what we had. And if we bring the buccal mucosa to the lingual, then we are moving the lining mucosa into the area that we will need the attached gingiva later. Also, we'll have to make vertical incisions. Here, the more we preserve the vascularity of the buccal and lingual mucosa, the better the bone grafts underneath would work. So we are putting a suture with minimum tension to secure the edges of the gum. Now the gum edges will be a little closer to each other because we reduced the height of the crestal bone on the lingual. But on the buccal, it's more or less where it was pre-operation. And this is how the patient goes home. The area is well sutured, and the important thing is that Teflon should be well tucked under the edges of the gun. Okay, so this is the periapical view of the postoperative work. You can see it's a 6.5 millimeter by 8 millimeter implant. We are confined to the height of the adjacent root, which is the rule of thumb to avoid damage to the nerve. And it should be good. These areas have the bone graft. They should heal around it. This is a panoramic view. Yes, the main nerve is all the way down here, but if you remember that accessory nerve is somewhat here, but still we are far away from it and we should be good. So this was the immediate extraction and placement. Now, the only thing patient will have left is a minor surgery to expose it, which we're going to wait probably 4 months, 4 or 5 months, and depending on what we see when we expose it, maybe we wait another month after that. But in 4 months' time, in a case of a mandibular placement and use of bone graft that is not synthetic bone graft. Synthetic bone graft, we'll have to wait about 6 months. But if you're using allograft, which in this case we used allograft and some xenograft, mixture of allograft and xenograft, then it should be ready in about 4 months' time. So I hope you enjoy it. If you have any questions, you can contact us at Global Academy of Oral Implantology at implantedu.org.